Okay, and I'm going to move to share my screen. All right, so I would like to welcome everybody to the actually, oh, it's up here. I would like to welcome everybody to the second of two modules of the Health Data Literacy Training in 2017. This one is titled Preparing and Presenting Diabetes Data. So before we go into the actual training, I just wanted to spend a few minutes and go over some background and acknowledgements. So the funding for this training was provided by the American Indian Alaska Native Health Disparities Grant Program through the Office of Minority Health. Should be a call number. I don't have the number. Okay. So we are the Urban Indian Health Institute. The mission of the Urban Indian Health Institute is to support the health and well-being of urban American Indian and Alaska Native communities through information, scientific inquiry, and technology. We conduct a variety of public health and research projects from surveillance to training, and have recently expanded on our evaluation capacity. We attempt to fill in the gap of information concerning urban AIANs. We were established in the year 2000, so we've been around for approximately 17 years, and we're a division of the Seattle Indian Health Board. We focus on serving urban American Indians and Alaska Natives with a focus on urban Indian health programs. We are one of 12 epidemiology centers. So here we have a map of the UIHPs that are within our service area. So in total, there are 33 urban Indian health programs across 19 states and 101 counties. So it's quite an expansive area. We may not have enough time now, but I think it's worthwhile to kind of go in and look at what sorts of services are provided to, or what each of these places kind of offer as far as services. So this is funded through the Demystifying Datagram, and it's focused on eliminating American Indian and Alaska Native health disparities. This is achieved through information, partnerships, and training. This work aims to increase awareness of health disparities and improve the health and well-being of urban American Indian and Alaska Natives. The Health Data Literacy Training seeks to increase the capacity of urban Indian health programs to use data to address health status priorities. So in going into this current training, I just wanted to be able to kind of present an overview and outline of where we're planning on going with this training. So we're going to start by reviewing the previous module to give people an idea of where we're coming from, what information we're using, and where that all kind of came from, and also just to kind of reorient people to what we just went over. We are then going to be gathering all of the data that we acquired in the previous module to be able to use it and present it within this one. We're also going to be identifying target groups and discussing some of the considerations that we may take into account when preparing data for those groups specifically, and then looking at choosing data and sort of like what data is important, what may be more useful in certain situations, and out of these big tables, what's going to be most advantageous for us. So the first module focused primarily on creating and refining a research question. So getting out of this more nebulous space of what I want to help AI and health, to then how can we kind of refine that? Okay, well, we were able to identify that diabetes seemed to be an area of interest, an area for intervention, and then from that, how do we sort of operationalize and define the different aspects of diabetes and quantify its impact on American Indians and Alaska Natives? At this point, we then explored attempting to find relevant data sets to AI and diabetes. So we went about evaluating each of these data or multiple data sources, finding them on the web, and trying to find databases that were not only accessible, but large enough that we were able to draw some aspects or draw some conclusions about the data that we were interpreting. And this is particularly hard with AI and data because oftentimes, even within these very, very large national data sets, they're a very small proportion of the entire sample. So from that, we were able to find the Behavioral Risk Factor Surveillance System, or BRFIS, the Youth Risk Behavior Surveillance System, or URBIS, an online data portal through SAMHSA, which has a health and drug use survey, and then additionally through CDC Wonder find mortality data. After this, we exported each of the databases we found after we were able to identify whether or not they had diabetes-specific data, and created some file naming conventions so that we were able to access that data later. So after acquiring data, and sometimes even before, I think it's worthwhile to start to think about what groups are going to be targeted by this information. It may also be the case that we have a certain amount of information, and from that, throughout time, we sort of like decide to present it or compile it in different ways, depending upon what new group we're going to be giving the information to. So in this type of a situation, I like to start off with 3 general categories. And in this situation, I group patient and community sort of together, grant policy, and then providers. So as with anybody who's consuming information, a lot of these groups are very similar. And a lot of them have various things that are quite the same, but to that same end, there are also a lot of things that make it unique. I like to think of these as more sort of like general categories where there may be situations where providing things that you may present to a patient or community would make more sense for providers than vice versa. So we'll move on. So when I'm preparing data for patient or community members, I jotted down a few things that I like to take into consideration. So one is reducing the need for explanation. Oftentimes what I find for lay people or less data savvy individuals is sometimes more complex data presentations can really turn them off to exploring the information that you're attempting to present. So I try to reduce a lot of this auxiliary information that needs to be taken in order to understand the general numbers. This helps decrease the amount of time and energy that's needed in order to understand. Also, sometimes what you find in AI/AM communities, but also just communities in general, is oftentimes there's this association between the amount of words and descriptions being used and a general feeling of sort of distrust. So sort of this idea of, you know, the more I have to kind of go in and feel like I have to dig through what you're writing, the more I kind of am waiting for that gotcha moment. You know, so I try to kind of reduce the amount of words and context that needs to be applied to the numbers I'm presenting so that they are very easy to understand. Okay, and just for sound quality's sake, I went through and muted anybody. So if anybody wants to chime in at any point, just feel free to unmute yourself. It's just sometimes ambient noise can kind of get in through the audio. Also, within the same right, I like to reduce reference groups. So it can be quite tough to understand for people who are less data savvy what reference group means. So if I were to tell you that AIANs were 40% more likely than non-Hispanic whites to, you know, say drink water, well, what does that really mean? How do I really understand that? It's not as easy as being able to say 60% of AIANs drink water. I need to be able to understand all these other things in order to even understand the way that those two groups are referenced in relation to one another. So I try to stay away from this. It could also be less important or not even relevant to the target group. As an AIAN, if I were to hear that I am more or less likely than non-Hispanic whites, well, that may not really mean anything to me. I want to know about how that risk factor affects me as an individual, not how I compare to my neighbor or other people. And it can help create a nice, clean, concise message. And I think that's very important when attempting to kind of communicate with people. Also, for quite a few AIANs, there's this kind of expression of feeling demoralized. So if we're constantly kind of hit with the same message of AIANs being X% worse than non-Hispanic whites or any other reference group, well, that can get very tough over time to constantly feel like you're underperforming. Additionally, when I look at presenting numbers for grant or policy advocacy, there's very much a need for comparison. Oftentimes, if we just present a low number, it may not have that much relevance if it isn't placed within a particular context. We also want to be able to understand the way that presentation will change the end results. This may be in understanding the way that presenting a rate might change if you decide to change it to a proportion, so on and so forth. So really being able to kind of plan for the back end to really understand what's going to put you where you need to be. Additionally, there's an increased need for the ability to test the numbers that you're presenting statistically rather than just kind of presenting the numbers by themselves. Additionally, statistical tests and presenting those sorts of methodologies might actually end up confusing your message if you're presenting it to community or patient populations. Additionally, focusing primarily on need. So being able to kind of put your numbers into a context of why what you're attempting to do is important. being able to kind of figure out and quantify what importance is, and then being able to look at things such as rates versus proportions. The last group that I have, or that I try to think of, is providers. Now, I think of the three categories, this is probably the one that I provide information less for, but I always think that it's really interesting to try to take into consideration, because there are some unique factors associated with this group in general. So there are quite a few similarities to both grant groups and community groups. And I think that it really sort of like fluctuates on that continuum based off of like what data is actually being interpreted. So with this group, I always try to kind of keep the adage that like time is money. So with that, I really try to keep information simple and easy to read. It needs to be able to be digested fast, but have relevant information to what they're doing. Within many situations, there's also a need to focus on comparisons. This isn't always the case, but in a lot of times it is quite relevant as far as being able to quickly inform those providers. Additionally, focusing on need so that as providers, they may be able to address those needs. But also deciding to target and tailor the information for age groups that they treat. If they primarily work with adults, it may not even be useful or relevant to present information on adolescents, and vice versa. Additionally, I try to stay out of health statistics that don't offer a clear means for intervention. So say if I were to be presenting mortality data, while it may provide some useful information, more malleable factors like BMI or eating behaviors might actually be more relevant than just being able to kind of display in term what the overall likelihood for that group dying from diabetes is. All right, so we're going to move into our first data output. Now, this is from the CDC Wonder System, and it was an analysis that we did for a 5-year period from 2015 or 2011 to 2015 on the rate of diabetes death in urban American Indian and Alaska Native populations across the US. So moving forward within these data tables, I tried to highlight and bold some of the information that I thought was going to be most useful when moving forward. Now, after this point, what we're going to be doing is taking these numbers and sort of dividing and tailoring them to each of the 3 groups that I mentioned prior. The reason I do this is because oftentimes I think that there's this tendency to kind of think of numbers or statistics as really stagnant, instead of looking at it as a more dynamic and interpretive process that will change depending upon how you're deciding to use those numbers and information. So when looking at these tables, the things that I thought were really interesting was up here. So American Indian and Alaska Native females had a relatively high age-adjusted death rate for diabetes. Likewise, we can also see that American Indians and Alaska Natives had an elevated age-adjusted death rate for diabetes when compared to non-Hispanic whites. So those are both sets of numbers that I'm attempting to highlight. So now we're moving into sort of the data presentation. So if I were going to be presenting data acquired from this table to a patient or community population, I might go into it very wary. So with this group, oftentimes what we find is, doing percent increase or even just kind of age-adjusted death rates may be difficult for these groups to understand. So if I were to tell, you know, I was sort of trying to think about things like if I were to tell my grandma, how would she understand it? Now, if I told my grandma that 19.1 in 100,000 people are going to die from diabetes, well, that number doesn't really make a lot of sense. Likewise, if I were to also talk about our increased likelihood relative to non-Hispanic whites, well, that might be really difficult for her to understand. So being able to kind of create a message that say more urban AIANs die from diabetes than non-Hispanic whites, well, that's a clear and concise message. Within that same sort of situation, I can provide links to more of the detailed information for those people who are interested, but not really taking my one chance at being able to create buy-in and use it to kind of confuse the person who's reading. So really just trying to lend itself more towards being as plain as possible. One thing that people may not necessarily know and may be also worthwhile in highlighting for this population is how much of an increased risk women are at dying from diabetes than non-Hispanic whites. So taking the same information, if I were to be then presenting it for a more data savvy population, like a grant application or trying to advocate for some form of policy, I would do something like the following. So I would take my group of interest minus my reference group to get the absolute difference between these two and divide it by my reference group. So what we end up with is 0.79 or 0.079, sorry about that. So in interpreting it, what we can say is urban AIANs were at an 8% increase or experienced an 8% increase in the likelihood of dying from diabetes when compared to non-Hispanic whites. So this kind of tells a different number. In being able to present the absolute rate within this sort of document, it may seem a little bit underwhelming. For those of you who have not worked with mortality data, an age-adjusted death rate of 19.1 isn't really all that high. So it might lend somebody to look at it and say, well, you know, what's really the point of intervening here? Whereas if you can sort of compare these two rates, being able to present an 8% difference might sort of allow them to interpret the information in a different way. Likewise, we do the same thing with the women's specific rates. So being able to kind of take our group of interest, subtract it from our referent group, and then dividing it by the referent group gives us 0.343. So what that tells us is that from this information, women are at a 34.3% increased likelihood of dying from diabetes than non-Hispanic whites. Now, I think that this is actually quite an interesting number, as oftentimes I feel like I haven't seen quite a few diabetes initiatives focused at women specifically. So this might be an area where we're able to really identify those areas of need and use it to sort of target that population. So in this type of a situation, given sort of some of the considerations that had to go into patient or community populations, if I were to be providing information to providers, it would probably be more weighted towards the grant or policy. So being able to really kind of focus on some of these comparative components as opposed to absolute rates. So here we have information obtained from the BRFIS. I think this is 2015. So here we have estimates for body mass index for both whites and American Indians and Alaska Natives, and those endorsing having been diagnosed with diabetes. This is split up into three categories. So those who only had diabetes during pregnancy, those who had diabetes, and those who were at or borderline or pre-diabetic. Additionally, we have sort of normal BMI categories: underweight, normal weight, overweight, and obese. One of the interesting things here is that we sort of see this crisscross of essentially taking normal weight putting it into obese as far as the overall percentage of the whole, and here. So what we see is that we are less likely to have normal weight and more likely to have obese. And this is the exact opposite for non-Hispanic whites. So one of the transformations that we could potentially make when presenting this data to patient and community populations is taking the overweight and obese categories and adding them. The subtle differences between the two groups may not necessarily be as important when presenting the information to these groups. Additionally, it may create more of an impact to be able to say 68.9% of AIANs are either overweight or obese. That number may carry a different weight than if we were to say 34.7% were overweight, 34.2% were obese. Additionally, if we wanted to focus on those at highest risk, we could then create numbers like 34.2% were obese and 2.3% were pre-diabetic or at risk. All of these numbers are really important and might be useful in different situations, but here I hope you can also see how easy this information is to digest and how quickly we can approximately understand what's going on. I find that to be very important when presenting data to less data savvy individuals. Additionally, we can say that 14.7% of AIANs had diabetes, with 1.2% of those surveyed only having diabetes while they were pregnant. Now, one thing to take into consideration when viewing this is the fact that it is 1.2% of the total surveyed population and not of just women or pregnant women. Those are important things to highlight and oftentimes can be sort of confusing when we're taking in all of the information, because I oftentimes feel like my first inclination is to think 1.2% of pregnant women or 1.2% of women, when in reality that's taking in all men and all women. So likewise, when we're taking this data and attempting to kind of understand it in a different way, say like for grant and policy reasons, we can then kind of do similar transformations to those things that we did before. So again, taking our group of interest, minusing our referent group, which is 10% for non-Hispanic whites, over our reference group gives us 0.47. Additionally, when we move into the calculation for those diagnosed but only during pregnancy, we can do something similar with 1.29 minus 0.9 over our reference group gives us 0.33. So from that, we're able to say that urban or AIANs are 40% more likely to have diabetes, and they're 33% more likely to be diagnosed during pregnancy. Now what we're doing is taking some of these numbers that relative to the whole might not necessarily seem like big, important numbers, but when we're able to extrapolate them to their relevant reference group and kind of create some of these percentages, we're able to sort of see how much of a disparity actually exists, even though the overall rate is relatively small. Likewise, we're able to look at the overall percentage of the group that were either obese or overweight. So for AIANs, this is 68.9 minus our reference group. So this is the percentage of non-Hispanic whites who are overweight, divided by our reference group gives us 0.6 or 0.069. Likewise, we take the likelihood of being obese minus the likelihood of non-Hispanic whites being obese over our reference group, and that gives us 0.2. So from that, we're able to say that urban AIANs are 6.9% more likely to be obese or overweight, and additionally, AIANs are 20% more likely to be obese. So from this data, what we're able to kind of show is not only are AIANs more likely to be obese or diabetic across the spectrum, but then particularly with the increased, such a severe increased likelihood in being obese, it's very divergent as far as their overall likelihood of being, like, I guess, worse off. So in this situation, if I were to be providing the information to providers, I think it's very similar to the patient community. I think that a lot of these numbers are easy to digest, and as far as being something that's immediately recallable while seeing a client, it's a lot easier to remember 68.9% are either obese or overweight than trying to remember exactly what the increase in percentage is, and then figure out how to interpret that and use it as a means of intervention. So here we have the SAMHSA Health and Drug Use Survey. These are both estimates for diabetes rates or those who are endorsing diabetes in Native Americans or AIANs and non-Hispanic whites. So when you move into how to interpret this from a patient or community perspective, I think it's really interesting because oftentimes we're faced with this sort of like strength or deficiency based sort of conundrum when it comes to preparing and presenting data. So we can go in, and this may change as a function of what we're hoping to get across to each of these populations. So it's easy enough to kind of lead off with this idea that 28.3% of AIANs were diabetic. Okay, well, that might serve and be useful to some populations as far as deterring them from engaging in particular activities, but it might also serve to kind of demoralize and turn people off to the idea of actively working towards a particular goal. Now, what we can do is take the exact inverse of that number. So they provided us that 71.65% said that they weren't diabetic. So likewise, we could take this number and use it as a means of being able to empower and rally the Native population around a particular goal or behavior. So this is kind of like being able to say, look at this amazing number, 71% don't have diabetes. What can we do to kind of keep that trend going up? You know, this might work towards empowering a different type of population where the original number might actually have the exact inverse effect. So I always think that this is something to really take into consideration, because sometimes it's really easy to get stuck on the number that you find interesting. So for me, it's oftentimes is 28.36%, but I really need to be able to remember that that also means that there's a 71.65%. So in moving in, we see similar sorts of calculations with grant and policy. So I won't go over this again, but what it leaves us with is based off of these estimates, AIANs are 30% more likely to have diabetes than non-Hispanic whites. That's a very eye-catching number, and also something that's very relevant. Additionally, this is a situation where I feel like the percentage is starting to get high enough and relevant enough that it might be important to kind of take the number out by itself for its own consideration when being presented with these increases in likelihood. So being able to also say, well, look, this estimate says that 28.3% of AIANs have or endorse diabetes. So this is a situation too where when providing information to providers, really kind of looking at various aspects of both of these numbers. So maybe being able to provide some of these strength-based numbers, like the percentage of AIANs without diabetes, while also kind of talking about some of the increased likelihood. Both of these numbers might serve well in conjunction to not only provide providers with information relevant to what they're hoping to do, but then also kind of some of those strength-based numbers to be able to say, well, look, let's kind of keep this trend going. So this is some of the information that I find particularly interesting. And this is from the yearbus, so the youth. So this is all K through 12 data. on various health behaviors by children. One thing to take into consideration when analyzing data from this source specifically is that compared to the BRFIS, their sample sizes are relatively small. So here we can come to see that there's approximately 159 AIANs and approximately 6,700 whites who answered the survey. Now, we also kind of see, given the confidence intervals, that these are very kind of wide margins. So it might lend itself to be difficult to analyze. But with that being said, oftentimes trying to gather and present data for American Indians and Alaska Natives, we're sort of in a situation where we have to kind of take what we can get. You know, try to come to the best prudent conclusions that we can given our limited information. So as we go through this, we see that there are informations about soda, or the frequency with which they drink soda, and then also the frequency with which they drink sports drinks. So high sugar drinks increase the likelihood of diabetes, particularly when we're looking at children and sort of developing these habits that are going to be long-standing. So these are going to be the numbers that I'm going to attempt to highlight in the following slide. So what we find in patient and community settings is, you know, being able to kind of come in and say, look, 86.3% of K through 12 AIANs said they drank a can of soda in the last week. This might be one of those big numbers that really get somebody interested in, say, the poster or bulletin that you're presenting, to then say, wow, that doesn't really seem like where it should be. And, you know, maybe get motivated about being able to implement some type of policy change, or at least getting more interested in the subject matter in general. Additionally, we can come in with this other number where 21.8% of K through 12 AIANs drink at least one soda pop each day for the last 7 days. And that's quite an alarming number, and something that we want to be able to intervene with and really highlight. Now, the nice thing about presenting data for this population is that, you know, oftentimes we get around some of those difficulties with wide standard error by being able to highlight the number without really worrying about how it relates to the referent. Additionally, likewise to the can of soda, we can see that 72.2% of AIANs endorse having drank a sports drink in the last 7 days. Moving back to this sort of like strength-based idea and interpretation of data, we can take the total population, which would be 100%, minus the population endorsing having drank at least or one soda in the last 7 days, and what we end up is with 78.2. So that's the number of K through 12 AIANs who did not drink a can of soda each day in the last 7 days. That might be useful information in being able to get initial buy-in from people about implementing some type of health behavior change. So being able to come in and say, well, look, regardless of what you think, look at this big number. That number didn't do what you think is so normal. So moving into grant and policy, these numbers are oftentimes difficult to analyze because of small sample sizes. So that's something to take into consideration. But again, when presenting the data for each of these groups, there might be a need to use the information that you have access to. So in looking at sports drinks, we take AIANs minus the referent over the referent, and we get 0.303. So what we're able to say is that AIANs had a 30.3% increase in the likelihood of having had a sports drink over the last 7 days. Likewise, when we look at cans of soda, we're able to say AIANs had a 19% increase in the likelihood of having endorsed drinking soda in the last 7 days. Yeah, and here I feel like with the numbers being so similar and some of the ability to kind of statistically test these differences between the two groups, providing medical professionals with sort of these general estimates that we might provide the patient or community groups would be most beneficial. So being able to kind of look at how this provider group changes dynamically in relation to each data set. So here we find estimates as far as activities. I find these quite interesting. So here in our first group, we have did not participate in at least 60 minutes of physical activity on at least one day in the last 7 days. Watched 3 or more hours per day of television on an average school day. Did not play on at least one sports team in the last 12 months. Had obesity. Described themselves as slightly or very overweight, and were not trying to lose weight. So here I'm going to split this up into 2 slides, as I feel like as far as being able to find numbers and create potential means of intervention for patient and community members, there actually is quite a bit going on. So here we have sort of the strength versus deficiency-based paradigm again. So we can come in and say that 13.6% did not have at least 60 minutes of activity over the last 7 days. Or conversely, we can also say that 86.4% did endorse having exercised at least 60 minutes a day in the last 7 days. So being able to kind of really highlight this positive number and try to use it as a way to springboard people into making positive changes. Likewise, we can highlight this disparate number of 30.4% of American Indians and Alaska Natives endorse watching more than 3 hours of television on average per day. That's a big number that's going to be able to kind of reach out and hopefully grab people's eye and increase their interest. Additionally, we can say that 41.8% of AIANs were on the sports team in the last 12 months. So this might be an area to kind of understand, you know, is it that they're participating in a lot of non-sports related activities, or is it that the number itself represents an overall decrease in activity? Additionally, we have some of these other numbers with 15.9% being obese and 39.8% describing themselves as slightly or severely overweight. As far as these perceptions, I mean, that's really an important question to understand in being able to kind of say, well, is this a reflection of reality, or are there perhaps body perception issues going on? Additionally, we take this number or percentage of children who are actively trying to lose weight and subtract it from the total total percentage. And what we find is 51.4% were actively trying to lose weight. So as we move into grant and policy, we sort of do similar calculations where we're able to take our group of interest minus our reference group over the reference group, and we find 0.52. From this, we're able to softly conclude that AIAN children were 52% more likely to have watched 3+ hours of television in a day. I mean, that's a pretty divergent number and probably a strong area for consideration when developing interventions. And then likewise, because we're not able to really directly analyze a lot of these numbers to the reference group, so here we sort of find that with such disparate confidence intervals that in the previous module for actually even test these, they're probably not going to be statistically different. It might be a specific situation where we need to instead just highlight the percentages by themselves in the way that they exist. So being able to just highlight the fact that 13.6% endorsed no activity in the last 7 days, and 15.9% were classified as obese. And then lastly, this might be a situation when preparing this information for providers, being able to kind of provide the information that we can about overall likelihood, while also being able to kind of take a chance to present any of the comparisons that we were able to make, especially because given the sample sizes of each population, it might be difficult to come to any other sorts of conclusions. Okay, so this was our second module from the Urban Indian Health Institute. What I provided here is just some general information about how to get into contact with the Urban Indian Health Institute. We got phone, fax, email, and website. Now, two of the things that we're primarily involved with is technical assistance and data requests. And oftentimes these are two areas that are relatively underutilized. So I'd welcome anybody to get into contact with us if they find that they have a need for either data or understanding data or any other sort of question that we may have the capacity to help any of the organizations viewing this with. So with that being said, I was going to offer up some time at the end of the meeting to potentially go over any questions that anybody might have about what was being presented today. I don't think that I could hear you. Was it Adriana? I'm gonna